patients with undifferentiated shock. So this one did. So emergency department very frequently, right? I mean, how many times, Jacob, have you seen a patient that you have no idea what is going on, but you know that they're dying?
That's yeah, at least, like, I want to say an 8 to 25% of my patients are going to be that. They're like, you know, I don't know what's happening with them necessarily, but I know that if I don't do something, they're going to die, or they might die.
Right. So let's start off with kind of a small case. So you have let's say a 45-year-old male coming into the emergency department, and he looks sick. Something about him seems off, and EMS brings him in, puts him on bed, and assessment. You find him to be a little hypotensive, probably, let's say, 85 over 50. He's tachycardic, tachypnic, and he just doesn't look good. Something about him makes you concerned. So at this point, the way I like to think about it is you have this puzzle, right? This 500-piece puzzle that nobody knows really what to do. Like, you have to start putting this thing together in order to kind of get the bigger picture. Can everybody see the slides?
Mm-hmm. Yep.
Oh yeah.
So what I like to do is I think the approach is very important. And I think the approach for people is different depending on what year you are. So is that my intern year, when I would come in, and Andrew and have felt this way or may still feel this way, and that's completely fine. This is basically what my thought process was, right? It was completely blank. I didn't know where, and stood there. Like, how many times, Jacob, do you remember being an intern, like, you would stand there and just freeze? Or maybe you're a lot better than I was.
Yeah, I think you're just a bad doctor. I'm just kidding. No, that's everything, man. I mean, there's still some shifts right now where, like, I see a patient and I'm supposed to know what's going on, and I'm like, I'm not 100% sure what's happening right now. You know, that still happens. But, like, it happened a lot more before, but.
What about, like, your mental approach? You remember when you just go there and just, like, you know that you know everything, you've done well on your test, the knowledge base is there, but it just always leaves you. It's like you don't know anything anymore, and you don't know where to start, you don't know what to do. And for me, I had an algorithmic approach to these types of patients that I was able to kind of get myself out of that situation. Now, Yang and Andrew, do you guys remember feeling this way?
Yes, definitely.
Yeah. Do you guys still feel this way? That's completely okay.
Sometimes. I mean, the super sick people, sometimes you get scared at first, but.
Exactly. So what happens, though, is that as you kind of move into your second year, you start, like, gaining so much knowledge. After doing all these other rotations, you know a lot more. You know kind of what things you have to remember. It becomes that you start having to worry about all these different things. You don't really know, again, where to start, because now you have information and you don't know where to begin. The problem is that with both approaches, both methods, if you don't have an actual approach, you kind of look like a bunch of monkeys throwing shit at each other.
I love this so much.
But it also, your resuscitation kind of looks like that as well, because nobody knows what's going on. Nobody knows who's in charge. Nobody knows what to do. And if you don't have your specific approach, then you don't know. So Andrew and Yang, you guys have been doing this for almost a year now. How do you guys do this? Have gone into these rooms. You guys have seen more and more critical patients, and in my opinion, you guys are doing a great job. But you guys have to have some sort of system when you see these patients.
I don't know about Yang, but I mean,
anything?
You know, I always, it was beat into us, so it always helps to do ABC, you know, IV, O2, and monitor right off the bat.
Right.
And then, with that guy, I guess it all depends on the case and kind of what you see, but a 40, like middle-aged guy looks sick and those vital signs, you probably want to, assume infection or try to get a history or talk to him, kind of gathering information first.
Mm-hmm. What about you, Yang? You might not have the microphone on. Anne, what about you? How would you go about approaching these patients? And I know that you haven't really had a chance to actually practice real medicine in the real world yet, but you will soon. So do you have an approach that you've kind of learned already, or are you kind of in this situation where you don't really know what's going on?
Well, you said, if they were stable or not, I would talk to them, see if they're mentating okay, if this is something that happened all of a sudden, or if there's someone who's been sick.
Right. What about you, Jacob?
I agree with Ann. I mean, the first thing, it's the IVO2 monitor. And then can you talk to them, ABCs, and just kind of start from there. That is the same thing I do. I mean, it makes it like a good starting point. Like if you don't know what to do, you just fall back on those things, and it's actually a phenomenal way to start.
It is, right? Because for me, I feel like if you have something that's automatic, until you start like kind of figuring out like, so that puzzle start falling into place, starts going, and you start forgetting how scared you are or how confused you are, and that you kind of jump into resuscitation mode, and then all of a sudden things place, and you start becoming this different animal, like this person who all of a sudden knows everything. Like you and I have kind of been able to see residents do resuscitations. Have you kind of noticed how they kind of stay quiet initially?
Yeah.
And then once things start fitting into place, all of a sudden they take over and take charge.
Yeah.
And I think that's great, but you have to have that process that's automatic, that while you are still kind of figuring things out, you're getting things done. So I think IVO2 monitor is a great way to do it, and then do your ABCs, right? It's really easy to just kind of go in there, put the stethoscope on the patients, check for a pulse, talk to the patient. Information is not really that difficult to do. So my method is, and I think first of all, you have to be able to identify the patient, the sick patient, right? How many times do you walk by, and Jacob, you've been through our emergency department, you walk through the 60s, which is our critical beds.
Yeah.
By the room, and the patient may be admitted, but you kind of take a step back and be like, oh, that guy doesn't look good.
Yeah, that guy's color's off, or like the vital signs look weird, or they're doing that like death breathing,
Right. And that's I think that's important. I think that's one of the most important things of resuscitations is being able to identify the sick patient, because they're not always going to come in with, or they're not always going to come in hypotensive and tachycardic, right? I mean, we see a ton of hemonc patients. We see a ton of people who don't have the best immune systems, and something else that just doesn't fit the picture of a healthy patient. Something that doesn't make this patient fall into that category of, oh, yeah, let's just give them Zofran, challenge them, and let them go home. Come in, and you're like, oh, yeah, initially you're like, Zopo, go. But something about them all of a sudden catches your eye, maybe something in their history or something in their old charts that makes you rethink your entire assessment of the patient. Have anything like that, Jacob, that kind of makes you concerned about it?
I don't know. The main thing is just the way that the patient looks in the vital signs. I mean, the labs, I mean, I've had people with like lactates of like 8 that are like awake and talking to me and don't really have that bad of a blood pressure. It's a lot of it is just the way that it looks, the patient looks. And that's, one of the, I think, more important things to be able to identify sick, kind of like what you said.
Yeah. It's identifying the cause. Then Jacob, I think I'm gonna need a little bit of your help here with the rush exam, but I think most of your information comes from the history, right?
A lot of it.
I mean, yeah.
I mean, I guess the only issue is that sometimes you don't have like the history. Like that definitely helps, but sometimes, I mean, you just don't have like you have nothing to go on, and then the history is not as helpful. So the history you have is awesome, but
how many times have you had a patient come into the hospital and about the patient, or the family members who came in and have no idea what the patient is,
Yeah,
which
right.
past medical history is, and they don't have any. The patient's completely somnolent, so you can't get any history from them.
Right.
Debated. You don't know, so you can kind of go through and figure out what they're doing. So, physical exam and vital signs are also really helpful. On physical exam, even though we don't really do much in the emergency department all the time, but lung exam, the cardiac exam, and the neuro exam gives you quite a bit of information, and also just kind of pushing on their belly to figure out if this is a surgical. So when I listen to the cardiac exam, I'm really for either distant breath sounds or some sort of large murmur that might be concerned for a newly ruptured valve. When it comes to the lung exam, not really much, except for maybe if I can hear pulmonary edema, like consolidations or rails. Although, Jacob, I know you probably have a completely different thought on
my stethoscope broke 4 months ago, and I've not replaced it.
But I mean, if you hear something, it does kind of point you in a direction, right? I mean,
Sure.
It doesn't necessarily tell you, it may not be completely sensitive or specific, but it does kind of aid in pointing you in a certain direction.
Sure.
As far as lung exam goes, also distant breath sounds or lack of breath sounds may be concerned for a spontaneous pneumo or a traumatic pneumo. And then finally, your belly exam. If you push on it, it's really distended. There may be a hollow viscous perforation or something surgical that needs immediate intervention. Now, as far as what vital signs to look out for, hypotension, temperature, tachypnea, tachycardia. I would say of all of those, what do you guys find to be the most useful?
You talking about out of like the vital signs? Or no, you're talking about the physical exam, right?
Yeah, physical exam.
Yeah, I don't know. What do you guys?
On vacation?
Is that Nick? I can't tell. He looks like so chill that I have no idea what he's doing. Like I can't even recognize him.
I hate him.
What are you even doing, Nick? I didn't even know that was Nick.
But I mean, what do you find to be the most useful vital sign?
Wait, can you guys hear me? Can you hear? Mm-hmm. So probably the most useful vital sign for me is the heart rate. Because the patient could be in like really bad shock and have a blood pressure of like 105. And so like hypotension is definitely something that's bad, but if someone looks sick, everything's normal, but their heart rate's like 130, I'm like super concerned about it. Usually their respiratory rate, it could be high, it could be low. But if I had to pick one, if I was like on desert island, it'd be the heart rate. The next thing would be respirations, and then blood pressure. That's kind of like my order. I mean, I want all of them, obviously, but I mean, that's the one that I like the most.
I think in general, the heart rate is one of those things that right? I mean, anytime you are about to discharge a patient and you see a heart rate of 113 or 120, or you're walking by a patient's room and they're sitting there completely fine and they're tachycardic, it's always something that's like, hold on, like,
yeah, right.
Think that.
Makes you
whenever you look fake or something that is rarely erroneous, right? I mean, a blood pressure can be the cuff, or it could be a large person that pressure on, or it could be in the wrong place, or tachypnea can be something that can be faked, or somebody's anxious. But tachycardia is rarely something that you can just fake. You know, like I can make myself hyperventilate, but I can't really make myself tachycardic. Right. So for that reason, that's always kind of something to be one of the truest vital signs for me, and always kind of concerning. I wanted to move on to the rush exam because I think the ultrasound gives you a lot of information. And for you guys who haven't gotten a chance to hear Jacob talk, he's got a great rush exam lecture, and I think he's going to probably give it to us, right?
Yeah. I'm getting the last image ready to go now. I just got a new computer, so I am kind of struggling to like make sure all my like fonts are up to date, and they are. So let me just render this video. All right, let me switch over to screen share. Maybe this button.
It should be over there in the green.
Oh, I see it. All right. I just want everybody to look at Nick. Everybody look at him. There he is. All
just
right.
Look.
Just look at him. All right. All right. So if at any point y'all lose connection or something, let me know. All right. So we're going to talk about ultrasound in shock. And the way that we do that is basically by doing what's called the rush exam. The rush exam stands for rapid ultrasound and shock and hypotension. It's got a fancy name. It's rush because you want to do it quickly and it's important. And the mnemonic to remember the order for the rush exam is going to be high MAP, as in the kind of thing that you want your patient to have. You want them to have a high MAP, mean arterial pressure. So each of those things stands for a thing, and they're actually kind of in the order that you should probably do them. The heart, the IVC, Morrison's pouch, which is the fast examination, the aorta, and the pulmonary examination. So let's start with the heart first. So the H. There's basically three things. You want to look for global function, right heart strain, and then the presence of a pericardial effusion or a tamponade. So let's start with global function. And so there's like 4 different ways you can do it, but we're going to talk about these 2. Just looking at it visually, and then something called the EPSS, which I'll mention here in a bit. Let's hide this. We don't need this. Hide you. All right. So the EPSS is kind of what you do when you're starting out. Like you're these little like mini monks. And then when you're like super good like this guy is with balance, then you can do visual estimation. So starting out, EPS is a great way to go. Once you get a couple under your belt, you can switch to just kind of looking at it and knowing. So the best, you can use any view of the heart to look for ejection fraction, which is essentially what you're doing here. But the best one is going to be the parasternal. No, I am much buffer and hairier than this. So I look more manly. This is my hand right here. This is one of my residents. So for you guys, for us in Chattanooga, the probe marker goes on the left hip, but for you guys, the probe marker is going to go over to the right shoulder, and you're going to get maybe an image on the left and maybe an image on the right. One of the not you, Farhad. What is this? Is this good or is this bad? One of you guys. Bad? Am I here by myself?
No, you got some people. They've got their microphones off.
That's fine.
And what does it look like?
I can't see it.
Oh,
no, I can.
Oh, sweet. All right.
It only shows it when you talk.
Oh, really? Oh, you can actually like
here.
Yeah, go ahead. On the Hangout, you can like click on me.
Oh.
Box.
Got it.
Stay on this video.
So the one on the right is bad. Spoiler alert. This is a low ejection fraction. This mitral valve is barely moving. This is a great ejection fraction over here. So we got a ejection fraction of probably a good 60%. That mitral valve is like basically slapping that septum there. This is good. This one's bad. So when you're starting out, you can do this EPSS thing. And I'm going to take a look at the good looking heart over here. I'm going to zoom in on it. Sorry, I got the trackball of death here. Stand by. There we go. All right. So you can stick that M mode cursor right through the leaflets of the mitral valve. And trackball once again. Give me it. All right. So the M mode. Sorry, Fire. What were we saying?
So EPSS is a specific. It's a measurement, right?
Correct. Yeah. So you're going to stick your M mode transducer, which is a measurement like distance over time, put it right over the mitral valve, and you're going to get a tracing that looks like this. On the y-axis, that's distance of the thing that's on that line. And on this axis, the x-axis, it's time. So it's basically how things move over time. And we are going to zoom in. And right here, you see how there's like 2 humps? That is the mitral valve itself opening during systole. So the E point is when you have that first pressure change. It's the kind of big movement of blood. This is the atrial kick, this A wave. So you want to look at the difference between, or the separation between the septum and the E point here. And you can actually measure that. And if it's greater than 1 centimeter or 10 millimeters, it's very specific for heart failure. If it's less than 7, you don't have heart failure. If you want to remember one number, just remember 7. Less than 7, meaning it opens up, it gets really close to the septum, it's great. If it's greater than 7, meaning the mitral valve does not open up that much, it doesn't get close to the septum, it's more concerning for heart failure. All right, that's right heart strain. Excuse me, that's global function. Let's move on to right heart strain. So with right heart strain, you're going to do an apical 4-chamber view. So it's kind of right underneath the nipple there, right underneath the inner nip line, like I like to call it. And you're basically looking for the ratio between the right ventricle, which is over here, and the left ventricle. This should be about 1/3 of the entire width. This should be about 2/3 of the entire width. All right, so this right here, Farhad, does this look normal or abnormal?
Don't look good.
All right, so it is a little dilated like the whole thing. Ejection fraction is a little bit low, but I'm speaking specifically about the ratio between the left heart, which is over here, and the right heart over here. So this left heart is much bigger than this right heart. So this patient does not have right heart strain. And if we compare that to this guy, the next guy over here,
thing you can also see here. Oh, never mind.
all right, so over here we have left heart is smaller than the right heart. So this is a big right heart. This is a small left heart. So this, if you see this, be concerned about right heart strain. You see this little thing up here? You see how it's very hyperkinetic? Over here, the lateral portion of the right ventricle is not really moving all that much. But over here, you see a very hyperdynamic apex of that right ventricle. This is called the McConnell sign. It's concerning for something that's acute. Because remember, someone that has COPD, they have pulmonary hypertension at baseline, they can have right heart strain. But this is thought to be more specific for an acute process, like a PE. All right, and this is just
is your probe marker still on facing the other direction?
Your probe marker is going to be facing towards the patient's right with the UK machines, I believe.
On that one, where was it?
On that one, it was on the other side because like we have ours flipped in Chattanooga. Yeah. All right, so this is just a, what's that? All right, so this over here, this is a completely blown out right side of the heart. So this is just a massive PE. So yeah, it's like twice the size of this left ventricle over here.
Kind of just talking in general, since we're talking about PEs, this is important thing to rule out or rule in very, very quickly. Because Jacob, you were kind of like this is on MCRIT quite a bit. The circle spiral of death for massive PEs.
Right.
So it affects your management a little bit, doesn't it? I mean, normally we see these hypotensive patients that come in and we're like, give them 2 boluses, right? 2 bags of fluid.
Right.
But Drew Yang, and with a massive PE, if you give them a lot of fluid.
Yeah, so if you give those guys a lot of fluid, I mean, it might help, but it also might just like volume overload them because their heart can't handle it, right?
Well, yeah. So they may actually paradoxically become more hypertensive, right? Because they're giving them more preload, but they don't have anywhere to push that preload. So your septum actually starts to blow into.
Right.
So then you actually make your patient more decompensated. The other thing is that if you have a patient that is hypotensive and about to crash, do you intubate these patients that have a massive PE or not? And
I try to avoid it.
Yeah, it depends clinically kind of what your situation is, but oftentimes if you have an altered patient and you want to automatically just give them 2 bags of fluid and intubate them, PE, then you want to think about those 2 things very carefully.
That's a good call.
Sorry to interrupt.
No, you're fine, man. You're fine. So I'm gonna move on up to the pericardial effusion here. So this is a subxiphoid view. So you stick it right under the xiphoid process. Right side of the heart here, left side of the heart here. This is a normal echo and no pericardial effusion. And I want to compare that with this over here. Moving forward. Let's see. All right. So we see that peritoneal long axis view of the heart here, a right ventricular outflow tract here. This is the left atrium, mitral valve, left ventricle going into the aorta, and there is fluid all the way around here. So just all circumferential around there. This is an aorta, descending aorta, and you can see that this fluid is actually going anterior to the aorta. And that's actually important because you can actually see left-sided pleural effusions on this view as well. But for those, you'll see fluid go behind the aorta. Now, this patient, even though they have an effusion, doesn't necessarily mean that they have tamponade. It just means that they have an effusion. The right way to tell if you have tamponade is to look for diastolic collapse of basically any of the chambers. It has to be ventricular diastolic collapse or atrial diastolic collapse. That being said, sometimes you don't need any of those signs. I mean, look at this guy right here. This is just like a big old like clot in the pericardium. I think this patient had like a gnarly dissection, and that's how it ended up in there. All right, and here's one that's definitely tamponade here. Now, if you see when this mitral valve is open, that's diastole, right? So when this mitral valve is open, that's diastole, and that's when this right ventricle is collapsing. You do not want a chamber to collapse while it's trying to fill. So right there, the mitral valve is open, so diastole, and that right ventricle is collapsed. This is what tamponade looks like.
Interesting.
Yeah. Sorry, I think it's the screen sharing that's making it go kind of slow between the transitions. Yeah. And if you guys have ever seen an EKG with electrical alternance, this is what the heart's doing inside the pericardium. So if you see this, you don't even need to like look for heart strain, you don't need to look for ventricular collapse. It's just that's electrical alternance. That's tamponade. That's it's badness. All right. The other thing is that if I ever am on the fence, in fact, not on the fence all the time, I look at the IVC. This over here is a very flat IVC. This is a very non-flat IVC. You see how the patient's breathing. This is the diaphragm right here. It moves down. The patient is not collapsing at all. This is a very high central venous pressure. This is an extremely low central venous pressure. If you have a patient that you think has tamponade and they have this, they don't have tamponade because you have to have a high CVP to have tamponade. If you're on the fence, you're not sure if a patient has tamponade, and you see this guy right here, this is, if you have an effusion with a really high CVP, like you see here on the right, be very concerned for tamponade. So I always check the IVC.
Do you look at the actual size of the IVC, or do you just look at the?
So I don't do measurements. I'm kind of like a Sith. I'm all good or all bad. I don't really like gray areas very much. If something is gray area, then I just don't worry about it because I think it becomes more useless at that point. Basically, if it looks plump, it's high, and if it doesn't look plump, it's low. I don't do actual measurements.
What about PEs? Do you use the IVC as a kind of thing to point towards maybe a massive PE if that's also plump?
Are you talking about, did you say TAPSI? Is that what you're talking about? Or are you talking about the IVC?
The IVC for PE.
Yeah, no, I look at that. I do. The only problem is, it's not really a problem, but this is presuming that your patient's in shock and they're in shock from a PE. If they are in shock from a PE, the CVP will be elevated, but a low CVP does not exclude a PE. Does that make sense? A low CVP does not exclude a PE. It just excludes a bad one. Does that answer your question? Yeah, sweet. So basically do the IVC, you just turn your transducer. You're already in the subxiphoid view, right? So you just turn it with the pro marker facing up, and you can actually use this to decide if the patient has what kind of shock they have. So we talked about it. Low CVP is collapsing, high CVP is not collapsing. And you can kind of stratify these as, you basically your different forms of shock, even though it doesn't really diagnose anything. So low CVP, you have hypovolemic distributive, which is septic shock, and then neurogenic shock. And if you have a high CVP, you have obstructive and cardiogenic shock. So this IVC, which is the I part of HIMAP, doesn't really diagnose, but it'll help you put things more likely to be in one category or another type of shock. So that's the I. Move on to Morrison's pouch, which is the M, and that's basically it's just the FAST exam. With the FAST exam, it stands for, I mean, I think a lot of us know this already. It stands for the Focused Assessment of Sonography in Trauma. And you're basically looking for blood in the pericardium or in the peritoneum if you're doing like abdominal FAST. There's a order that you should do this, in my opinion, and that is because this is a binary question. Is there blood or is there not blood in the belly? And the most likely place for blood to accumulate is in the right upper quadrant, followed by the pelvis, followed by the left upper quadrant. So I always start the right upper quadrant. So start right about up here. Now, if you notice the right upper quadrant, it's a little bit lower than the left upper quadrant. That's because the liver is big. So you got a much bigger window. Fluid's going to accumulate a little bit lower. The spleen, it's much smaller. So you always have to put your probe a little more posterior and a little more cephalad. So to the bed and to the head. And notice all of these, my probes are sagittal or coronal. So the probe marker is always facing up. I don't really like transverse views for the FAST. So this is the first one here, is the right upper quadrant view. We got the liver over here, we got the kidney over here, and this right here is like the Morrison's pouch area, and that's kind of the first place that we need to evaluate. However, you always have to make sure to look down here. This is the caudal tip of the liver and the inferior pole of the kidney. This little triangular space right here is where fluid actually accumulates first. You haven't done a good right upper quadrant examination unless you get that inferior pole of the kidney and the caudal tip of the liver. Super important. A lot of people actually forget that. So don't forget that. And here is a positive FAST. So if we only looked in Morrison's pouch, if we just looked right here, it's, I don't know, maybe a little bit of fluid, but maybe not a whole lot. But we're looking over here, the caudal tip of the liver, and you can easily see fluid right there. So that's why it's so important to look there. This is the pelvis. This is the next view. You have the bladder here, and you have fluid. It'll be above. That's actually a good amount of fluid in this one. It'll be superior and maybe a little bit posterior to the bladder. So if we go back here, a little bit posterior to the bladder. Because remember, this is anterior. You get your probe marker facing up. This is anterior. This is posterior. This is cephalad or to the head. This is caudate or towards the feet. So the problem with looking at it transverse is that it's kind of difficult to know that if the thing that you're seeing is seminal vesicle or if it's uterus or something like that. So I always look sagittal. It's a lot easier. The left, more accurate actually, in my opinion. So the left upper quadrant, it's not really a mirror image of the right upper quadrant. You actually have to look suprasplenic. So you have to look above the spleen on this one because that's the most likely place for fluid to accumulate. In the right upper quadrant, fluid will accumulate over here. Left upper quadrant, fluid will accumulate here. The only thing with that is that you got to remember that patients kind of they'll do whatever they want, right? They might present in the classic place, but they might not. So you have to do a thorough examination, but know that you haven't done a thorough right upper quadrant unless you've done the inferior pole of the kidney, caudal tip of the liver, basically the bottom part towards the feet part. And then you haven't done a good left upper quadrant unless you've looked above the spleen. So with AAA, greater than 3 is considered abnormal of the aorta, and that's easy. So AAA, it's 3. If it's greater than 3 centimeters, abnormal. And then if you have greater than 5 centimeters with hypotension and you don't have another cause, it's a ruptured AAA. I mean, that's your diagnosis right there. You always got to make sure you measure outer wall to outer wall because the inside can actually have clot in it. So it might make the lumen look smaller than it actually is. So you always got to do outer wall to outer wall. So this is how you do the exam. You place the probe in the epigastric area, and you're looking for this little knobby thing right here. There's some bowel gas. You just got to push harder, get it out of the way. So I'm just trying to get out of the bowel gas here. And sometimes you have to go a little bit below the bowel gas, which I'll do there. So here's aorta. Here's spine. Then IVC will be somewhere over here. So you just follow that all the way down until you get to the split of the aorta and the iliac. So, hey, I don't know whose mic is on, but I'm like hearing myself. Sorry. So there's the split right there. So it was 1 aorta, now it's 2 iliacs. And that's how you do your aorta examination. Show you some abnormals.
In general, though, your aorta, if it ruptures, it may be normal, right?
It's very rare for a normal diameter aorta to rupture, but it's within the realm of possibility. I mean, that I see that more in trauma than anything. Sometimes with dissections, you'll see like a 2.5 or maybe a borderline 3 centimeter aorta with a rupture, but it's uncommon for it to rupture if you have a normal sized aorta. And that's why if you have greater than 5, which is pretty abnormal, with hypotension, I mean, you just assume it's AAA. Does that make sense?
Right. But I guess my question is that your aorta can, if it ruptures, can collapse down to a roughly normal size. Is that correct or incorrect?
I've not seen that. I've not seen that, but that does actually make sense. But I've not really seen that. Have you seen that, or you heard somebody like mention that somewhere?
I just thought that was like one of the things to remember. I thought when I was reading back in probably medical school, just kind of stuck in my head. I don't have any literature or anything to support it.
Okay. Well, I'll look it up. I'm not sure of that happening. I mean, all the ruptured ones I've seen, which is not a whole lot, but I've seen a couple. They have like an identifiable AAA. I mean, I think if it goes back to normal, it probably, if the patient's died already, like there's no blood in there.
Right.
Maybe. Yeah, no, that's a good question. I'll look that up. I'll let you know. All right. So this is a AAA here. And this is why it's so important to look at the outer wall to outer wall. Because if you only measure this right here, this is like 2 centimeters. Like this is perfectly fine, right? But this is actually the diameter of the aorta. Again, this all in here is clot. So you don't measure the visible lumen that's beating. You measure outer wall to outer wall. That is a pro tip right there. And it's a mistake that I've made too. Outer wall to outer wall with your AAAs. And I think and here's another one here. You got bowel gas in the way. If you have bowel gas, you just kind of push. When your aorta over here reaches the diameter of the lumbar spine, it's abnormal. The lumbar spine actually spent like a whole day once looking up what the normal diameter of the vertebral bodies are. And in the lumbar area, it's actually 5 centimeters is kind of the average. So if your aorta is getting to like greater than half the size of your vertebral bodies, it's time to measure it. I don't measure all my aortas, just the really big ones. This is just like a disgusting aorta I wanted to put in here. This is actually it's a 13 centimeter aorta. And this white stuff right here are stents, like old stents, and they like blood's like going outside of the stents. The spine is down here, by the way. Like this is the spine that's 5 centimeters in width. So this is like 13 centimeters.
Like an aorta that has kind of like revascularized itself and then clotted off and then revascularized.
Yeah, it was gnarly. Like I don't even know what you do with that. Like, I think you just give up and be like, all right, here's, I don't know, like some food. Sir. Sorry. All right. So the P part is a pneumothorax and pulmonary effusion. Pneumothorax is something that we typically do with like an EFAST exam, but we'll talk about it here. So you can use your curvilinear transducer, but the linear transducer is going to give you the best resolution image. So I'd place it there. And this is what you're looking for here. This is the ribs over here. We got your rib shadows underneath. We got our intercostal muscle here, skin, subcutaneous tissue, and muscle. And then underneath here, you have the VPPI, or the visceral parietal pleural interface. This white line is always going to be there, and everything underneath this white line is going to always look the same. This right here is the last real structure that you can see in an air-filled lung, and everything underneath is actually an artifact. This white line is basically it's the interface between air and not air, right? So even if you have a pneumothorax, you're still going to have that interface. But the question is can you see the relative motion of the visceral pleura with the parietal pleura? And that's actually what you're trying to figure out. So I'm going to show a little animation here. This is something that's kind of confusing for people. So we have the visceral pleura is down here. So the visceral pleura is on the lungs. The parietal pleura is what's kind of stuck on the rib cage. And what you're seeing relative motion of those two things. So this is what lung sliding is. It's just those two pleura touching back and forth, sliding back and forth between each other. And like I said, this white line is always going to be, the question is it sliding or is it not sliding? Yeah, so there it is sliding. All right. All right. Let's try ball of doom here. Yeah, I really feel like it's a screen capture thing because it hasn't done this. Anyways, so right here, we have rib shadow, and you see this white line sliding. This is a lung that does not have a pneumothorax. And we'll look at this next one, and you'll see that it is the same white line. Like that white line looks identical. Everything looks identical. The difference is that white line is not sliding back and forth. So give me a second. This will load right there. So you see it's the same image. It looks the same, but this white line right here is not sliding. It's because this patient has a pneumothorax. So sliding rules out a pneumothorax. If you don't have lung sliding, it probably means that the patient has pneumothorax, but there are other causes of no lung sliding. Like if a patient's apneic, if they're like a really bad COPD or that's obstructed, they're not going to have lung sliding. So over here, we see lung sliding on the left side of the screen, and we don't see lung sliding on the right side of the screen. See that? This is called a lung point. This rules in a pneumothorax. This is essentially the border of the pneumothorax. So if you're not 100% sure if the patient has a pneumothorax, look for this lung point. If you see the lung point, you've ruled in a pneumothorax. So lung sliding rules out a pneumothorax. A lung point will rule one in. So that's kind of the difference. Actually, I always look for both.
You go for both. How do you just kind of like go down the anterior chest and the lateral portion of the chest and just kind of look for it?
Yeah. Yeah, so if I see the absence of lung sliding, like I see like the lack of lung sliding, I will turn the probe transverse. So I'm usually sagittal, like my probe marker is facing up when I'm looking for lung sliding. I'll turn it transverse. So basically it's a long axis is in between the intercostal space, and then track it laterally. So start anterior and track it laterally towards the armpit. And look for it that way, because it's a lot easier to get the ribs out of the way that way. Does that make sense?
Yeah, gotcha.
Yeah, all right. So lastly, the last thing is a pleural effusion. So there's two signs here that we're going to look for. We're going to look for the mirror sign and the spine sign. See these little humps right here, right there and right there. Those are the lumbar and low thoracic vertebral bodies. And notice once the diaphragm starts, which is right here, they kind of disappear, right? Let me pause it. They kind of disappear. Like the patient still has a spine in their thorax, right? But if you have an air-filled lung, it's actually going to block the sound waves from getting to the thoracic vertebral bodies. So if the ultrasound machine can't see it, it's not going to be there. So if you see the spine stop at the diaphragm, the patient does not have a pleural effusion. Now, if you look here, you can see at the spine, I'm going to pause it. See that the spine actually extends above the diaphragm. Remember, you have the, let me rewind here. You have the, probe markers facing up towards the patient's head. This is anterior wall. This is the back right here. So you have a spine, and a spine. You can see that above the diaphragm, you can actually now see the spine. This is a positive spine sign because you can see the spine extending past the diaphragm. That is how I rule in a pleural effusion. You have this thing called the mirror sign, which is basically if you see that similar echo texture above and below the diaphragm, you can say that that there's air in the thorax. It's kind of a complicated mechanism, and it's kind of out of scope of what I want to talk about today. But basically, if the echo texture above the diaphragm and below the diaphragm are identical, it's very unlikely for that thing to be a pleural effusion. If you see it different, like you see here, so here it's very like mixed density. Here it's just straight up hypoechoic. This is a pleural effusion. So spine sign and then mirror sign. And that is the quickest way I can do the rush exams. Remember, heart, IBC, Morrison's pouch, aorta, and pulmonary. And that's it.
That's probably like the best way to get like appropriate information to kind of guide your therapy.
Yeah, I mean the thing is like I kind of have this weird relationship with ultrasound. Like I love it and I know it well, and it's like kind of like my side gig. It's my side hustle. You know, like emergency medicine is the most important thing, but ultrasound is like my side hustle. And there's right. Some times where like a rush exam isn't going to help me because I know what's wrong with the patient. Like the undifferentiated shortness of breath, it's fairly helpful. And I don't always do all of them, honestly. Like sometimes I'll just do the lungs and do the heart and then finish because that's all that I think would be helpful for me.
But I mean, I think as far as like history and vital signs go, for example, I think in my humble opinion, I'm not an ultrasound guru or anything like that, but I think that for a patient that can't talk to you, a patient that doesn't have family member that can give like any additional information, the ultrasound gives quite a bit of
way good information. Yeah, agree.
I think in all honesty, I think one of the big things that it does is sometimes you end up with like I don't know what the like IDK, right? Like, I don't know what what cause is, right? The ultrasound
right
has shown nothing. It has a completely normal rush exam. but you have absolutely no idea what's going on with this patient. But I think that that's still valid information, right? If you know what it's not, if you know that it's not a PE, if it's not a pleural effusion, if it's not massive abdominal bleed, guides you in a certain direction that, hey, maybe this is sepsis. It's probably not a PE. It's probably not cardiac, because they have no local wall motion abnormality. They have no global dysfunction. I think you still get quite a bit of information from
Agreed.
that. I think the last few things that we need to talk about is just about what we do with these patients, right? We have this undifferentiated patient. That's fantastic, right? We can send this patient to where they need to go. If we don't, then we have to figure out what we're going to do with the patient. So in the absence of a massive pulmonary embolism, you can probably give them as much fluid as long as their cardiac and renal function are normal. But I think it comes to the point of when you decide to intubate these patients, what are some things that you account when you're about to tube?
So for me, I think that a lot of people get stuck on airway. And if the patient is oxygenating and the patient is able to be bagged or doing decent on the non-rebreather, I'm not necessarily going to intubate that guy. Because what will invariably happen if you intubate him, let's say the blood pressure is soft, it's like, I don't know, heart rate or a blood pressure of like 65 or something like that. Like it's perfusing, right? But it's just not perfusing well. You intubate that guy, you paralyze them, you take their endogenous catecholamines away. Like that he's going to die, right? So the airway thing is not something that I'm like super into unless like they're not protecting their airway or it's a hypoxemic issue, right? Then I'll do it. But I always try to optimize hemodynamics before I try to intubate, in summary.
Perfect. So is there any type of agent that you use in particular?
Well, I really like adrenal suppression and sepsis, so I always use etomidate. Actually, like that's actually not a thing, you guys. Like that is something that has been perpetuated kind of in literature. And if we give one shot of etomidate, it's not going to cause them enough. I mean, the average patient, it's not going to cause them enough adrenal suppression to actually cause any kind of measurable morbidity or mortality. So that is actually one that I use fairly often is etomidate. With ketamine, I like that as well. But it just depends. Like I'm not going to give a ketamine for like a person whose heart sucks, right? Because I don't want to give their heart too much stress. I usually don't do propofol because if I'm intubating in shock, they're usually hypotensive and propofol drops the pressure, you know? That's basically my thoughts on those big three sedating medications. What about you?
I mean, I think it usually depends on the patient. Oftentimes if it's something quick, etomidate tends to be in our box. Etomidate and sucks in our airway box, so it's easily accessible. But heart is good, and I'll probably use ketamine just because it depends on whether I think this patient is acidotic or not. If I think that they're acidotic, or aspirin toxicity or just really bad sepsis, at least that way I can take a look without taking their drive for breathing.
Right.
Because oftentimes I can look and I could probably put a 7 tube in, like as it's moving back and forth.
Yeah, you got to time it right.
But if I have time to think and do it the right way, then yeah, I'll grab the right medications to do it. And again, propofol is usually not the option unless I'm trying to. In fact, I rarely use it unless
just
it's
in general
sedate for a block or something, you know, or not block, like a reduction or something like that.
Right.
Like a shoulder reduction. I don't often use propofol for intubation anymore, just because I feel like there's better drugs out there.
I agree.
But I think again, the last thing that I wanted to touch on before I'll cut you guys loose. It's so long, but it's the treatment, and the treatment. I mean, it's pretty intuitive. If you know what the patient's cause is, then you treat them accordingly, right? If it's hypovolemia, the best thing to do is give fluids if it's like not bleeding, But if it's bleeding, then obviously you get blood, like a trauma patient or a GI bleed. Special if it's a GI bleed, specifically a varicose bleed, to do a massive transfusion of ELA. But I usually just if this guy's circling the drain, then yes, just that is possible. Then I'm a little bit more. I think a little bit more wait for the patient to get cross-matched because in the end of the day, the cross-matched blood is better. It just depends on whether you have time for it.
Dang, Matt Cuso, quit making me jealous. Jeez, look at that view.
Where are you?
Where even are you? Oh, that looks like Cabo. Is that Cabo? I can't hear him as Mike. Yeah, it is Cabo. Nailed it. 10 points. So I think like the most.
That it was Cabo.
I know you did, but I didn't believe you because I don't believe anything you said. I'm just kidding. So the most common cause of sepsis is shock. The most common cause of shock is sepsis, right? So like if you look at your average patient, it's going to be sepsis. So think that. And then if it's something reversible, Jesus, just fix it. If they have a tension pneumothorax, fix it. If they have a tamponade, fix it. They got a PE, fix it. If they're hemorrhagic shock, fix that. Everything else, sepsis, it's antibiotics, fluid suppressors. And then what's the other one? Neurogenic shock, like, sorry, you have spine problems. I can't do too much about that. And then cardiogenic shock was like a massive MI. They often need epi, norepi or epi, and they need definitive treatment. So just fix the underlying and supportive care is kind of how I think of shock in general, because I'm a simple man.
The nice thing is that it's a fairly, I don't want to say it's a simple disease, but for us in the emergency department, what we can do is fairly simple. Stabilize. That's our job, is to resuscitate and stabilize, and then get the patient to definitive management. Oftentimes when a patient comes in hypotensive, I don't think it ever hurts to give them a dose of antibiotics, broad spectrum antibiotics, because odds are it's probably sepsis.
Yeah, right.
Covering them quick and early is pretty benign unless you cause them renal failure somehow.
Jesus.
But other than that, but that's pretty much it.